Hey, hello everyone, and welcome. This is Joe Minardi. I'm coming to you live from the WVU Department of Emergency Medicine recording studios. And today I want to introduce you guys to some of the basics, the fundamentals, the things you know just to get the ultrasound machine on and get started with point-of-care ultrasound. I don't have any disclosures for you. Please take a look for my content on Twitter. It's all about ultrasound. And look for me on YouTube where I post some ultrasound related videos and other educational content. So, you want to be one of the cool kids and incorporate point-of-care ultrasound into your life. I highly applaud you for that, and I look forward to jumping through this journey with you a little bit and learning about ultrasound. It's an awesome tool, makes you better at taking care of patients, and I hope you enjoy it. So I'm going to just kind of walk through a couple of cases here that maybe will inspire you to see how ultrasound can help. And these are all real cases that I have seen where they've been maybe managed without ultrasound, and then seen how ultrasound can drastically help what we see with these cases. So the first one here, 2-year-old female, short of breath. She kind of looks sick. And this is their x-ray here. Looks like pneumonia, sepsis, right? So we admit them with antibiotics, fluids. They come into the pediatric intensive care unit, escalating vasopressors. They're getting kind of sicker, and then they have a cardiac arrest. It's a long code, and they get pronounced, and they don't make it. Now let's see what happens when we have similar case, but we use ultrasound early on in our evaluation to help us figure out what's going on with this patient. So same presentation, but we take a look with ultrasound and realize what's going on is this patient actually has some kind of bad pericarditis with huge tamponade, and that's actually the cause for their short of breath, maybe associated with another bacterial process or something that's going on. So we recognize the tamponade, we successfully drain it. This patient's able to leave the hospital completely intact a few days later. Much different case. The next one is a 74-year-old male, comes in for COPD, and they have leg pain while they're in the hospital. Vascular ultrasound's not available. It's 10 o'clock at night on a Saturday. So we're like, well, I don't know, maybe they have a DVT, maybe they don't. So we just start some enoxaparin empirically until we can get an ultrasound. The patient develops an abdominal wall hematoma, and they require transfusion, get a little bit sicker, and they don't die or anything, but it's not the greatest case in the world. But let's take a look here and see what happens if we can add point-of-care ultrasound in, and we're able to just look quickly and realize, hey, there's no big DVT here. We can hold off on the empiric anticoagulation, and then later, maybe a few days later, they're able to get a follow-up comprehensive lower extremity Doppler ultrasound that shows no DVT and confirms your findings. So we're able to save that patient some heartache, some problems, save some of the blood we need for other patients by just being able to take a look quickly at this patient in the hospital. The next case is a 32-year-old obese male, comes in after a motor vehicle crash, doesn't have any good IV access. And so we decide, they're kind of sick, so we want to put in a femoral line, and it doesn't go perfectly, as it sometimes doesn't. There's multiple sticks. Patient gets a big groin hematoma and an iatrogenic AV fistula, which is unfortunate and requires a surgical repair. Again, not a deadly outcome, but an outcome that we would prefer not to have to deal with, and these can happen. But let's say we do this with ultrasound, right? Same patient, same presentation, we're able to use ultrasound, and we place that femoral line in one single stick. No complications, no problems. That's why we like ultrasound. So that's why we're talking about this. And there are millions of examples we can do. There's tons of evidence. And so I'm not going to go through that in detail. This is not a journal club, but cases like that and evidence that backs up those kind of scenarios is why we care and why we want to implement point-of-care ultrasound across our health system. Lots of data out there that we can be more accurate and give more timely clinical decisions. We're safer. Our procedures are better. We can do more procedures that previously weren't even accessible to patients because they required other specialized radiology suites or specialists that weren't available. But once we have some basic ultrasound skills and can guide needles, we can do more things with ultrasound and offer our patients more procedures in more places. This is a very patient-centered initiative by implementing point-of-care ultrasound in a wide approach across our health system. Pretty much every non-psychiatry specialty has incorporated ultrasound into their clinical care to some degree, whether you're a urologist, even dermatologist, certainly an intensivist, a hospitalist in pediatrics or adults, OB certainly. Everybody is incorporating ultrasound to some degree into their practice. Millions of papers, millions of articles, just a few examples. So here we got primary care and general internists a review article on point-of-care ultrasound, looking at the critical care patients, the intensivists. These are kind of the obvious ones. Pediatrics in outpatient and inpatient care, surgery, especially in the pediatric world, but adults too, hospitalists in pediatrics, and then just general hospitalists in internal medicine, and even anesthesia is getting into this game in perioperative ultrasound to give them a better evaluation of their patients before they take them in induced general anesthesia. Not to mention, hey, we teach this to medical students. This is becoming a general medical skill for all physicians. So just objectives, this is CME, so we're going to talk a little bit about the benefits of point-of-care ultrasound to patient care. I want you, by the time you're done with this, to know how to pick the right transducer and settings, and I want you to recognize and correlate images on the screen with some patient anatomy, some real basic stuff. We're not going to get into specific anatomical applications with this little discussion today, but later on we're going to start with the foundation and later on build on that, and then just recognize some basic tissues and organs, and then more details to follow after today's brief intro. So a few fundamentals, things you really don't need a ton of technical knowledge to introduce ultrasound into your patient care. You do have to know how to choose the right transducer and setting to get started, and you really just need to be able to operate the depth and the gain on your ultrasound machine, and that'll get you to 90% of what you need to do with ultrasound and you're taking care of your patients. Obviously, as you get more skills, you're going to want to expand on that and learn a lot more, but this is enough to get you started and get you to where you can help patients within a couple of days. So first off, let's talk about transducers. I usually just break these down into high versus low frequency transducers. High frequency gives you higher resolution, but you can't penetrate as deeply into tissue. And then low frequency transducers, what they do is they give you more tissue penetration, but the expense is lower resolution. And so some of the applications, here's the kind of basic workhorses of ultrasound. There are hundreds of different types of transducers, but these are the most common. So you've got high frequency linear like this, that is used for superficial things, vascular things, musculoskeletal things, foreign bodies and tissues, abscesses. And then we've got this kind of moderate to low frequency curvilinear. We like this. This is kind of our abdominal workhorse and OB. Sometimes even some of the deeper soft tissues, or if we have just really big processes, big abscesses in the soft tissue or something, hematomas, sometimes we'll use this. And then the phased array over here, this is your cardiac workhorse. This is mainly for cardiac applications, although if you don't have this curve thing, you can use this for abdominal applications as well, and it does a pretty decent job. Those are the main ones. You want to choose the right one for what you're trying to do. So think high frequency superficial, and then lower frequency for deeper things. And then the shape does make a difference depending on what you're doing. The phased array is a nice kind of small footprint that helps you get in between ribs and those spaces. And you can usually just look at your ultrasound screen and you'll be able to tell by the shape that you see on the screen which probe you have selected. So if you take a look here, this kind of sector or phased array has this kind of small footprint at the top with the wide pie-shaped image. The linear generally has a linear top, and then this horizontal rectangle on the screen. Sometimes you can actually get it to widen out a little bit, but it'll have this flat top. And then the curvilinear probe has this curvilinear footprint here and this slightly pie-shaped, but not as drastic as the vector image on your screen. So you can usually tell by looking if you don't know which probe is already activated on your machine. So that's it with transducers. We're going to jump into the ultrasound screen, and it's going to maybe sound like a lot of stuff, but with a little bit of practice, your eyeballs pick this stuff up kind of automatically. So first thing, probably the most important thing on here is the indicator. And that indicator corresponds to something that's usually palpable and slightly raised on your ultrasound probe. And wherever this is directed on the patient's body is what the direction is on this side of your ultrasound screen. Most of the time we're going to have it directed towards the patient's head or towards the patient's right, which would mean either their head or their right side of their body is over here. And so that can help us keep oriented. So that would mean this is the patient's right side, left side, and this is always superficial and deep. Okay, so indicator, probably the most important thing on here. There's a few other things that we're going to point out. So indicator, as we talked, the probe name is usually up here somewhere in the corner. Usually you don't really need to see that. If you can tell by the shape of your image, you'll know which probe is already activated. The preset or the setting, that can be relatively important because you want to be in a setting or a preset that pretty much matches the tissue type that you're looking at. Some machines have 3 choices and some have 300. So you just have to decide how specific you want to get with the tissues you're looking at. The frequency, you may or may not be able to adjust this a little bit, but you want to make sure that if you're looking at the heart of a 300-pound linebacker, that you're not at 16 megahertz frequency, because you're never going to see anything. The max depth is usually listed over here. It's kind of good to know where your depth is. That's the depth, along with the gain, are the kind of 2 controls you're actually going to need to mess with a little bit as you're scanning your patient. And then by most conventions, there are depth markers on the sides that can help you not only see what your depth is on the screen, but you can also use these to help you kind of just eyeball sizes of things. If you see, okay, this is roughly what our scale is for structures on our screen, that helps us kind of eyeball estimate sizes. So the main controls, the most important controls I want you to be familiar with, we talked about depth and gain. So depth is the first one, and so just let's show an example here, and we can see in both of these we're looking at a heart, and we see here our depth is at about maxed out at 6 centimeters, and I can't make out a heart there. Can you make out a heart? I can't. Here we're looking at a heart and our depth is way too much, and so half of this screen is just wasted, and we can see the heart here, we can make it out, but we could probably make it out a lot better if we weren't wasting so much space on our screen. So those are examples of just depth and how that influences what you look like. And so too little or too much is not what you want. You really just want it just right, where the structure of interest is pretty much centered and taking up most of your screen. And you may want a little more, a little less, just depending on what you want to see. I generally like to see a little bit behind my structures, just so if there's anything back there that I don't want to miss, but I don't want to waste half the screen and lose my resolution, the structure of interest. So adjust your depth to get your structures of interest kind of lined up, mostly centered, taking up the majority of your screen. So that's depth. And then gain is image brightness, and gain is really like adjusting the volume on your stereo. It's not really changing the signal much. It's just either decreasing what you see or increasing what you see. And just let's look at examples here. So over here we've turned up the gain on the whole screen, and it's way too bright. It's kind of blinding our eyeballs over here. And in this situation it's too low, it's cranked down, and it's really hard to make out what we're seeing. And this is going to change depending on the lighting in your room, what your preferences are, but you want to get it where it's not blasting your eyeballs out, not washed out white like you see here, where this is kind of overgained and washed out. So that's where you start to get maybe distortion, like your speakers may distort if you turn it up too loud. But you don't want it so dark that you can't see anything. So you want to try to get it just right. Now, a lot of machines, again, depending on the machine you use, may have something called time gain compensation, or sometimes it's depth gain compensation. Those are the same thing, where you have either a physical slide rule where you can adjust the gain as you get deeper on the image, and a lot of times there is signal loss on your ultrasound, so it actually helps to have it kind of go down a little bit of a diagonal like this, because you are losing a little bit of signal as you get deeper on your image, and some of those sound waves get absorbed into the tissues. Now, in some machines this is a virtual thing, and some machines don't even give you this option because they try to set it up automatically on their own. But you do want to see this and know about it, and most importantly, you don't want these all kind of zigzagged across your screen. You want them to kind of be in roughly a straight line or a nice diagonal working their way down. So that's the gain. So depth and gain are the primary controls when you're first getting started with ultrasound that you're going to need to make adjustments to. So here are just some examples of how the time gain compensation may be changed or altered to affect your image. Here, this one looks pretty good. We see pretty consistent brightness kind of all the way from the top of our image all the way down. This one, overall, I think probably it's too dark, and we've probably undercompensated here, so just this whole band across our screen is dark. Kind of similar here, although the rest of this doesn't look too bad. Here we've compensated and turned our gain up too much at the top, but then we've lost it at the bottom. We have kind of a band of darkness across our screen. This little line kind of shows how we adjusted our TGC, and that would be suboptimal. So now we go into what I would call the obligatory ultrasound physics piece. Now, I'm not going to get terribly detailed into this. I just want you to get some basic understanding of how this thing is working. If you want more ultrasound physics, please see me after class and we'll talk about it. So ultrasound is just sound in a higher frequency than what we typically hear. So about 10 times what we would typically be able to hear. But it works the same as any other sound thing you might know from nature, like a bat or similar to sonar, anything else like that, where the sound leaves our transducer, it hits tissue or other objects in the tissue and then bounces off. The transducer is able to hear it and then reproduce electrical signals that give us an image on our screen. So just almost the same thing here, only instead of a bat, we have our transducer. And what I really want you to understand is, one, we're sending sound into tissue, the sound bounces back from the tissue into the transducer, but the most important functioning and working parts of ultrasound are actually in the transducer itself that's in contact with the patient. And so you don't want to drop those things, you don't want to break them, and you want to take care of them. But that's where the sound is generated, and that's how it's also received. So a somewhat important concept is that the transducer acts not just as a megaphone, but also as a receiver of the sound waves, and hopefully to give you nice, pretty pictures that you can interpret and make good clinical decisions on. That's it. That's the physics. So I hope you liked it. So ultrasound modes, there's a few basic modes that we're going to use, and let's just talk through those a little bit. So there's B mode, color mode, there's Doppler, and there's a couple different Doppler choices, and then there's M mode. Those are the main basic modes that we're going to use. And if you're an ophthalmologist, maybe you're going to use A mode, but we're not going to talk about that. And on this particular ultrasound machine, they are buttons across the bottom of the screen, but every machine's different. It's going to have their modes lined up in one place that's hopefully grouped together. You're going to have to look for them on whatever machine you have, but there's a couple of basic modes. So the first one, the most important one, the one that does almost all the work that we're going to do and care about, is B mode, brightness mode. Sometimes it's called 2D or grayscale. It's got a couple of different names. It's all the same thing, where you get basically black and white pictures of tissues or anatomy. And essentially what happens here is the ultrasound transducer sends the sound waves down into the tissue. Those sound waves bounce off of the tissue and then they come back. And how bright these images are depends on how intensely that sound is reflected. So if it's an intense reflection, it looks bright white. If the sound pretty much goes right through it, then there's really no reflection and it looks black. So in this example, this is the heart. We see that the dense connective tissue of the pericardium is an intense reflector of sound, so it looks bright white. The blood within the heart doesn't really reflect sound much at all, so the sound travels right through it and it looks black. Lots of other things like the myocardium here are shades of gray. And then we can't really see much else back behind here because there's so much reflection off of the pericardium. So intensity equals brightness of dots, and that's what 2D or B mode ultrasound looks like. Most important mode to have and use. And then color mode. So color is probably the next most common mode that we use, and this is available on most units, even our handheld units, so we need to understand this a little bit. So essentially we take an area of interest and we place our color box onto that area of interest, and then the system analyzes any kind of movement or flow inside that box for velocity and direction, and that's what it gives us, velocity and direction. Red and blue have nothing to do with arterial or venous, it's just velocity and direction. The colors represent direction. So in this case, you can look at the little scale on the side. So red is flow coming towards our transducer. Transducer's up here. And blue is flow going away from our transducer. So here, the blood coming in through the mitral valve towards our transducer is red. And as it swirls back around and leaves the heart, it looks blue because it's going away from our transducer. And there are some estimates of velocity. If you want to really look at what shade of red or what shade of blue, but for the most part, we're usually not looking at the color box for important estimates of velocity. When we want that, we want spectral Doppler. We'll get to that. So convention, blue is away, red is toward, although there are some scenarios where that may be switched. So always check your guide to make sure that it is as expected. So that's color or color flow, it's sometimes called, or color Doppler. Those are all the same thing. So if we want really detailed information about velocity as a direction, then we're going to use spectral Doppler. And it uses pretty much the same principles as color Doppler, only in a much smaller area with a little sample gate. So we place this sample gate in the area of interest to give us very specific and detailed information about velocity and direction of blood flow. And we'll get a graphical display, so it's displayed over time. And we have our kind of baseline zero line. Any waveform above the line is towards our transducer, and you can see it's a positive number. And if it's below the baseline, then it's away from our transducer, and you see a negative number for velocity. And you'll also get an auditory feedback. So in this example here, we've got the sample gate that's in a vein. So the blood flow in the vein is very low velocity, so we get this very low signal. There's not a whole lot going on until maybe we squeeze their calf, and we get a big spike of blood flow as the blood squirts up their leg. Here, that's called augmentation. So the velocity increases kind of forward and backwards, and that's what we're seeing here. So that's what spectral Doppler is. Most commonly, we're using a pulsed wave Doppler. There are some scenarios, mostly in cardiac imaging, where we use continuous wave Doppler. You don't really need that for the majority of ultrasound, so most of the time you can just say we're going to use Doppler, and that's usually pulsed wave Doppler. And that's why you often see the PW denoting pulsed wave Doppler. The next mode, not as commonly used, but used some. Most common reason I use it is for identifying fetal cardiac activity. There's a few other applications. This is M mode. M stands for motion. And so what we're using here, we're not using a Doppler effect anymore. We're essentially taking an image, we're placing this line or ultrasound spike across our image to then get an analysis of that single line and how it's changing over time. So this line is just transposed here and then being graphed over time. So the depth that's seen on this graphical display should match what is here, and any structure should line up in pretty much the same place. So here we have an M mode spike across the mitral valve, and the mitral valve sits in about the middle of our image, so the motion of the mitral valve is graphed in about the middle of our image. And we can get a lot of detailed things, especially for rapidly moving objects like valves, by analyzing them with M mode. So M mode is motion, and it's mapped over time. So look for that on your ultrasound machine, and that's really our modes. So B mode, which is the thing we use the most, color, and then spectral Doppler, which is usually pulsed wave, and then M mode for motion. And that's really our modes. So next, there are a few other modes that we use in some other special areas, but for our intro, we're not going to talk about those. All right, this seems like a good spot to take a break and then come back and talk some more about ultrasound physics. Man, do I love physics. So just a quick recap. We talked a little bit about some of the clinical scenarios and just how ultrasound can give you more, better, faster information at the bedside and help you give better care to patients and make you a better doctor. And I think that's something I continuously strive for, and I think we're all striving for. We talked about a few basic things about getting the machine on, getting the right transducer, getting the right setting, manipulating the depth, the gain, how to recognize just some of the basic things when we look at the ultrasound screen, and then we talked a little bit about the basic modes that we're going to use when we use ultrasound. So stay tuned and come back for when we're going to talk about some terms, some artifacts, and how to acquire images and what some of those things are going to look like. So stay tuned. It's been a pleasure. I'll talk to you soon.